Hello, I'm Dr. Coyne-Beasley, Professor of Pediatrics and Internal Medicine, Vice Chair of Pediatrics for Community Engagement, and the Division Director of Adolescent Medicine at the University of Alabama at Birmingham. Welcome back to our podcast series on COVID-19 vaccine updates. In this episode, I'll discuss COVID-19 infection in children and adolescents with a focus on health equity and health disparities. I'll start by talking about the current status of COVID-19 infections in children and adolescents overall. As of October 14th, nearly 6.2 million children and adolescents have tested positive for COVID-19 since the onset of the pandemic. From October 7th through October 14th, about 131,000 child COVID cases were reported. This means that children and adolescents represented 25.5% of the weekly reported cases in the United States. While this represents a decrease from the pandemic peak of nearly 252,000 child and adolescent cases reported the week of September 2nd, 131,000 cases remains an extremely and unacceptably high number of newly diagnosed children and adolescents. When the pandemic began, children and adolescents represented 14 to 16% of total cumulated cases. For the week ending October 14th, children were 25.5% of the weekly reported cases, and for children under 18, they only make up 22.2% of the US population. There are, however, some communities of children and adolescents that are disproportionately impacted by COVID-19 infection, as this pandemic has challenged healthcare systems and magnified health inequities related to systemic and structural racism. Children and adolescents of color experience significant health disparities related to COVID-19 infection. You may be asking, what are the racial disparities in the COVID-19 pandemic? We see them in almost every metric we look at. Data from the Kaiser Family Foundation of Research suggests that COVID-19 has disproportionately affected the health of children and adolescents of color in ways that mirror patterns that were observed among adults. Studies find that compared to their white counterparts, Hispanic, Black, and Asian children had lower rates of testing, but were significantly more likely to be infected. Black and Hispanic children were more likely to be hospitalized and more likely to have multisystem inflammatory syndrome, a serious and sometimes deadly condition where different parts of the body become inflamed, including the heart, lungs, kidneys, and brain. Black children were also more likely to be admitted to intensive care units due to MIS-C. And Hispanic, Black, and American Indian and Alaska Native children had higher rates of death. This is also confirmed by recent data from the CDC that also demonstrate racial disparities in COVID-19 health impacts. As of August 31st in 2021, there were almost 4.9 million infections, over 39,000 hospitalizations, and 725 deaths due to COVID among children 19 years of age and younger, which showed infection rates were highest among American Indian and Alaska Natives, Native Hawaiian, and other Pacific Islanders, and Hispanic children and adolescents, with cases at over 500 per 10,000 people. White and Black children had over 300 cases per 10,000, while Asian children had the lowest infection rate at just over 200 cases per 10,000 people. American Indian, Alaska Native, and Hispanic children had the highest rates of hospitalization, followed by Native Hawaiian and other Pacific Islanders and Black children, who were 2 to 3 times as likely to be hospitalized than white children. Asian children had the lowest hospitalization rate. And there were also large disparities in death for American Indian and Alaska Native and Black children, whose death rates were over 3.5 to 2.7 times higher than the rate for white children, respectively. Hispanic children also were more likely to die than their white counterparts, while Asians had a lower death rate. But there are many ways in which COVID-19 disproportionately impacted children of color, and they weren't always manifested in health outcomes. The pandemic also adversely impacted children's mental, social, and academic growth, with Hispanic and Black children bearing the brunt of these impacts. A recent study by the vaccine monitor of the Kaiser Family Foundation shows that half of Hispanic parents say one of their children fell behind academically as a result of the pandemic, compared to about 35% of white parents. Additionally, half of Hispanic parents say that their children experienced difficulty concentrating on schoolwork, that they had issues with sleeping and eating, or had frequent headaches or stomach aches since the pandemic began, compared to less than 40% of white parents. Black and Hispanic parents also are more likely to say that their household suffered a job disruption due to childcare needs in the past year, and to say that the disruption had a major impact on their families' finances and stress level. Other research has demonstrated that Black and Latino students disproportionately experienced learning loss during the pandemic due to a variety of reasons, including a lack of access to high-quality remote learning and high-speed internet. But we see that these disparities exist not only in health outcomes, but also in outcomes related to the social determinants of health. Why is vaccination important? Well, we all know that children ages 12 years of age and older became eligible for COVID-19 vaccination on May 10th of 2021. Ensuring equity in COVID-19 vaccinations among children is important for mitigating the disproportionate impacts of COVID-19 and preventing widening disparities moving forward. Moreover, because children make up a significant share of the population and are more racially diverse than the rest of the population, equitable vaccination among this group is key for achieving an overall high rate of vaccine coverage among the population and to help reduce disparities in vaccination rates more broadly. Unfortunately, it looks like there also may be disparities in vaccinations. There is a dearth of data to examine vaccination rates by race and ethnicity among children and adolescents on the federal level. However, available data, including data analyzed by the Kaiser Family Foundation, point to potential racial disparities in vaccinations. As of September 7th, 2021, we see that white children had higher vaccination rates than Black children in all 7 states. And there are only 7 states at that time that were actually reporting these data. What we did note, however, is while there were disparities between white children and Black children, the size of these differences varied widely across the 7 states. The vaccination rate for white children was higher than that rate for Hispanic children in 2 states, although the rates were similar or smaller, we should say, than the differences between the rates of Black and white children. Hispanic children had similar or higher rates of vaccination than white children in the remaining 5 states. In the states for which we were able to calculate vaccination rates for Asian children, the rate for Asian children was higher compared to that of whites. Another study that was done in September 14th of 2021 by Emory University, showed that while African Americans make up 12.5% of the US population, they only make up 9.9% of the fully vaccinated population. Hispanic Americans make up 18.4% of the population, but only 16.5% of the fully vaccinated population. And this data was for people of all ages. So what has caused these disparities in vaccination, or certainly what are the potential causes? Kaiser Family Foundation data reveal that Hispanic and Black parents are more likely than white parents to report potential access barriers to vaccination. Across racial and ethnic groups, the top concerns about COVID vaccine for parents of unvaccinated teens center around the potential for long-term or serious side effects in their children and adolescents. However, consistent with surveys of adults, Hispanic and Black parents are not only more likely than white parents to cite concerns that reflect access to vaccination, but also cite concerns about not being able to get the vaccine from a trusted place, believing they may have to pay out-of-pocket costs, or having difficulty traveling to a vaccination site. A larger share of Hispanic parents than white parents also report being concerned about needing to take time off work to get their child vaccinated. There are also historical and contemporary concerns or mistrust that some families of color may have. Hesitancy among communities of color may also include fears of racism and exploitation. From the torture of enslaved Black teen Lucy by Dr. James Marion Sims in The Pursuit of Gynecological Discoveries, to the Tuskegee syphilis study from 1932 to 1972, to the Guatemalan experiment in 1946 to 1948, whereby vulnerable Guatemalans were injected with syphilis, gonorrhea, and chancroid through a US-funded study, to recent racist beliefs about Black people having a high pain tolerance to justify undertreating pain in Black individuals, these historical and contemporary examples have caused mistrust. However, while I want you to be aware of these things, please do not assume medical mistrust in populations of color, and always, always offer vaccinations. What are some strategies to improve equitable allocation, acceptance, and uptake of COVID-19 vaccines for children and adolescents and families of color? I'd like to offer a few suggestions that are evidence-based. The first is work with communities of color, including adolescents and young adults themselves, to promote trust in COVID-19 vaccination efforts. You should also acknowledge racism exists in medicine and medical history as the first step in helping to restore trust in communities of color. You should also include all youth, including those attending schools and going where they are, such as sporting events and social activities. Even consider going to those who are living in close quarters or who may have unstable housing, such as the homeless, even in juvenile justice centers, and working with youth who also can serve as essential workers. It's also important to involve trusted community-based organizations such as churches, schools, tribal partners, and adolescent and young adult influencers in the implementation of vaccine allocation and in the location of actual vaccine sites. It's important to recognize that addressing equity needs to be intentional, and this may include prioritizing communities of color so that they can actually get access to the vaccination. And when you design vaccine outreach and messaging programs, make sure they are for adolescents, that you take in consideration the psychosocial developmental characteristics of young people, such as their desire to seek social inclusion and the importance of social media. When we're thinking about communities of color, it's also important to use graphs, voices, and videos that are appealing to all languages and learning style. And it is also important to inform individuals who may be migrant workers or undocumented individuals, or who are uninsured that the vaccine is free. Whatever strategies you use, it is important to incorporate strategies that address vaccine equity and the social determinants of health. This is critical. Vaccination is an important tool in conjunction with addressing inequities for eliminating health disparities related to COVID-19. As providers, we should be asking ourselves, what are the disparities in vaccination in our practice? And how might I improve equity in the allocation, acceptance, and uptake of COVID-19 vaccinations for children and adolescents? This will likely require efforts in and outside of the confines of our office. COVID-19 is a vaccine-preventable disease, and vaccinations have demonstrated the ability to eradicate diseases such as smallpox and polio, as well as reduce health disparities, as we've seen with measles. Assuring equity and increasing COVID-19 vaccination is essential. In our next episode, we will discuss the pediatric and adolescent indications for the COVID-19 vaccine.